All right. Hello, everyone. My name is Dr. Van Beest. I am currently a fellow in spinal cord injury medicine at the University of Washington in Seattle. And today I am going to talk to you about one of my passions, which is sexual function after spinal cord injury. And I did have a coworker do some translations for me, but I apologize if there are any inaccuracies. All right, let me make this a little bit easier to see, and we will get started. Okay, first, I would like to touch on the importance of sexual function and emphasize that sexual function is important to people of all ages, orientations, genders, backgrounds, and life situations. So yes, this means that it is important to people with spinal cord injuries, just like all people. In fact, multiple surveys have demonstrated that in the SCI population, sexual function is one of the most highly rated priorities dictating quality of life satisfaction. These results came from a survey where people with SCI were asked what their top quality of life priorities were after their injury. As you can see, sexual function ranked number 2 in those with tetraplegia and number 1 in those with paraplegia. Now, sexual function is a complicated process, and unfortunately, there is not enough time to talk about all aspects of sexual function and how they relate to those with spinal cord injury. So in this talk, I am going to go over some neurophysiology and then review some of the most common treatment options. So let's start with an oversimplification of the neurophysiology of sexual function. There are 3 parts of the nervous system responsible for sexual function. These are the sympathetic, parasympathetic, and somatic nervous systems. The sympathetic fibers originate from the T11 to L2 spinal segments and form the superior hypogastric nerve. The parasympathetic fibers originate from the S2 to S4 spinal cord segments and then travel as the pelvic nerve and the cavernous nerve to innervate the genitals. Somatic innervation is critical for sensation of the genital region via the pudendal nerve. So what does all this mean and how does it actually work? Let's start with genital arousal. Genital arousal includes vaginal lubrication for women and erections for men. There are 2 pathways by which genital arousal is controlled. These are the psychogenic and the reflexogenic pathways. For the reflexogenic pathway to work, the person must have an intact sacral reflex arc of S2 to S4. So basically the sacral part of the spinal cord along with the nerves that come in and out at the S2 to S4 level must be intact. The afferent limb of this pathway is via the pudendal nerve to the sacral cord at S2 to S4. The efferent component is via the pelvic nerve and causes engorgement of the erectile tissues. A positive bulbocavernosal reflex, or anal wink, confirms the patency of this reflex arc. The second pathway is the psychogenic pathway. And this one is a little more difficult. Psychogenic stimuli can be visual, imagination, whatever you want, just some sort of erotic stimuli. This triggers a response in the brain, which sets off a series of events that leads to signal outflow at the T11 to L2 segment of the spinal cord, which then travels via the hypogastric nerve and triggers genital arousal. This pathway is not as strong as the reflexogenic pathway, but it is still important for triggering and maintaining genital arousal. The function of the psychogenic pathway can be predicted by the degree of preservation of sensation in the T11 to L2 dermatomes. So in summary, those with a neurological level of injury above T11 to L2 will in general have an interrupted psychogenic pathway because the T11 to L2 sympathetic outflow is essentially disconnected from the brain, so it can't receive that psychogenic input, but they should have an intact reflexogenic pathway. Those who have damage to the S2 to S4 area of the cord will have an interrupted reflexogenic pathway and will be reliant on the psychogenic pathway for genital arousal. Again, the reflexogenic pathway seems to be more important or more reliable in the creation of genital arousal. This means that while those with a sacral level injury may be able to achieve some degree of genital arousal, meaning penile erection or vaginal lubrication, this will often be difficult to maintain and insufficient for successful intercourse. Now, it should be noted that these are old numbers. I could not find a more recent, concise summary. But as you can see from these numbers, upper motor neuron injuries, or those that preserve the sacral reflex, so they're above S2, are more likely to have an intact reflexogenic erection, and the reflexogenic pathway is most important. So they are more likely to be able to attain erections, whereas the complete lower motor neuron injuries, so those without an intact sacral reflex arc, are much less likely to be able to obtain genital arousal. However, the erections for all these levels may be unreliable, of short duration, or insufficiently rigid to achieve successful intercourse. So about 60% of men with SCI will use some sort of erection enhancement. Now, there's not a lot of great studies on this topic in general. This study was just a survey of 87 women with SCI, but maybe it can give us an idea of about how many women with SCI report adequate versus inadequate lubrication during sexual activity. Unfortunately, the survey did not include what level of injury the respondents were, but as you can see, about half reported adequate lubrication. The next topic is the ability to achieve orgasm after spinal cord injury. So physiologically, orgasms and the ability to achieve orgasm is a complicated process. I won't go over the details of the neurologic pathway because it's very intricate and not fully understood, but I will mention that orgasm is triggered by activation of the spinal pattern generator, which is located at the L3 to L5 level of the spinal cord. And another very important part of this process is, again, the sacral reflex arc. And those with an intact sacral reflex arc have a better chance of being able to achieve orgasm after spinal cord injury. So if the person has a positive anal wink reflex, which is a test of that sacral reflex arc, they have a better chance of being able to achieve orgasm than if they did not have a positive anal wink reflex. And just a fun fact, orgasms have been noted to significantly improve spasticity for up to 24 hours in the SCI population. Once again, the studies which provided these numbers were not great for a number of reasons, so take these results with a grain of salt. As you can probably guess, people with SCI are more likely to be able to achieve orgasm if they have less severe incomplete injuries. It is very, very difficult to achieve genitally focused orgasms in complete lower motor neuron injuries, so meaning injuries that damage S2 to S4. If the patient has voluntary anal contraction, a BCR, or an anal wink, it is a good predictor of the ability to achieve orgasm from genital stimulation. However, orgasms typically take longer to achieve than pre-injury, and orgasms are often reported as less intense. Next is the ability to ejaculate in men with SCI. Keep in mind that ejaculation can occur with or without an erection and with or without orgasmic sensations because these are all separate neurologic processes. The neurophysiology of ejaculation is another complicated process. One thing is clear though, and that is that injury to the spinal generator of ejaculation, which is located again at L3 to L5, results in failure to ejaculate in men with SCI undergoing penile vibrostimulation. And once again, the ability to ejaculate is higher if they have an intact sacral reflex arc. Men with SCI also may experience retrograde ejaculations, meaning that the semen will go into the bladder instead of coming out of the penis. This is not harmful because the semen is eliminated with the urine, but men should be advised that even if they do not see any output from the penis during sexual activity, it does not mean that there is no output, and some semen may still come out, so they may need to consider birth control if they are trying to avoid pregnancy. Ejaculation is more difficult after SCI when compared to pre-injury, and success has been reported variously between 5 and 70%. When utilizing hand stimulation, sexual intercourse, or penile vibrostimulation. 10 to 15% can ejaculate with masturbation alone, but this improves to 89% for lesions above L2. So meaning the spinal generator of ejaculation at L3 to L5 is more likely to not be damaged. And adding PVS plus or minus a sympathomimetic medication such as midodrine, which we'll talk about more in a little bit. Once again, ejaculation is more likely with incomplete as opposed to complete injuries and less likely in those without an intact sacral reflex arc. To wrap up this part of the talk, I wanted to just do a quick summary of the most important things to pay attention to on physical exam when it comes to sexual function after SCI. So in summary, on physical exam, you want to pay attention to if there's sensation in the T11 to L2 dermatomes, because this indicates an intact psychogenic pathway for genital arousal. An intact vulvocavernosal reflex or an anal wink indicates an intact reflexogenic pathway for genital arousal, as well as the ability to orgasm and ejaculate. Incomplete, as opposed to complete injuries, are associated with improved genital arousal, the ability to orgasm, as well as ejaculate in men. And finally, having a lesion above L2 suggests the person will be able to ejaculate. So we've seen an overview of the problems and how to assess them. Now let's talk about what we can do about those problems. For this part, I'm going to go from least invasive to most invasive treatments. So let's start with vacuum erectile devices as treatment for erectile dysfunction in men with spinal cord injury. A vacuum erectile device is a plastic cylinder placed over the penis. A seal is then created at the base, and activation of a pump creates a vacuum which draws blood into the penis, creating an erection. A rubber band or ring is then placed at the base of the penis to prevent loss of the erection. 93% of men with spinal cord injury using a vacuum erectile device reported sufficient erections for intercourse. However, by 6 months, less than 50% were satisfied, largely because they can often cause penile pain and the erections aren't as strong as those with other treatments. However, this is a reasonable alternative if the patient does not tolerate or doesn't want to use other treatments for erectile dysfunction. For ED and SCI patients, first-line treatments are actually not penile vacuum pumps, but oral medications such as PDE5 inhibitors like sildenafil or Viagra. All these medications have been proven to be effective in the SCI population, which is great. In general, they're about 80% effective. They are less successful with lower lesions that affect that reflexogenic pathway because there's less nitric oxide released from genital stimulation, and PDE5 works by delaying the degradation of nitric oxide. When prescribing these medications, be sure to monitor for hypotension, particularly in those with lower blood pressure at baseline, which is often the case in the SCI population. Also keep in mind that they are contraindicated with use of nitrates, which are often used for the treatment of autonomic dysreflexia. So if someone often has episodes of AD, you might want to reconsider the use of PDE5 inhibitors. Also, be sure to advise your patients with higher levels of injury who do not have an intact psychogenic response that they need to have genital stimulation to activate the reflexogenic response to release that nitric oxide, or it will not be effective. Another option for the treatment of ED is local penile vasoactive therapy, which is medication placed directly within the soft tissue of the penis, often with an injection. These medications bypass the nitric oxide pathway, so if the person does not have an intact sacral reflex arc, this might be a good medication to use. This tends to be very successful in the SCI population, with 85% achieving good or even excellent erections. However, there's a higher risk of priapism than with oral medications, so this needs to be closely monitored, especially in those with numbness or altered sensation in their genitalia. Overall, despite the needle, these medications have a high acceptance rate in the SCI population because of the penile rigidity that is obtained. And finally, the most invasive treatment option for men with SCI and erectile dysfunction are penile prostheses. Penile prostheses surgically replace a lot of the soft tissue structures of the penis. These are typically a last resort because, as you can imagine, they destroy a large part of the penis. However, they do have a high satisfaction rate owing to the predictability of erections. They do have a risk of infection, pain, and perforation, though. And obviously, it is a surgery, so again, it is usually a last resort. So what about women with SCI and genital arousal dysfunction? For women who have insufficient vaginal lubrication, perhaps from an interrupted reflexogenic or psychogenic arousal pathway, you can recommend that they use lube or approved gels. This can make sexual activity easier and more comfortable. PDE5 inhibitors like Viagra have the possibility of increasing pelvic congestion and vaginal lubrication in some women with neurological instability, but a significant benefit hasn't yet been proven in the SCI population. However, there was a significant increase in subjective arousal with the use of this medication, so that is cool. For the treatment of orgasmic disorders, you can encourage both sexes to participate in sexual self-discovery. Many persons with SCI report an area of hypersensitivity just above the level of injury that can be pleasurable if stimulated. In addition, after SCI, it is thought that heightened awareness of stimulation on sensate areas combined with psychogenic arousal can morph a previously non-sexual stimulus into a sexual one with time and repetition. You also want to minimize barriers to orgasmic function by minimizing medications that may contribute to sexual problems such as beta blockers, SSRIs, SNRIs, Lyrica, gabapentin, and baclofen. You also want to inform them that a longer duration of more intense stimulation is often needed to achieve orgasm. They may want to try medical grade vibrators, which have been shown to increase the chance of reaching orgasm. In addition, orgasmic sensations have been reported with episodes of AD during sexual activity, which we will talk about in a bit. In men with SCI, the chance of experiencing orgasm is increased if they are able to ejaculate. So often men with SCI pursue treatment for ejaculation disorders in order to experience orgasm and improve intimacy with their partners. To treat both orgasm and ejaculation disorders in men with SCI, you can use penile vibratory stimulation, sympathomimetic drugs, and Viagra. For penile vibratory stimulation, store-bought vibrators are rarely strong enough. You want a medical-grade vibrator with 100 hertz frequency and 2.5 millimeter amplitude. Rather specific, I know. And the efficacy of PVS goes up when you actually use two of these, so one on each side of the penis. Injury to the L3 to L5 segments is the sole independent predictor for failure of PVS to induce ejaculation because of damage to the spinal generator of ejaculation. Another treatment option is the addition of sympathomimetic drugs. One study showed that 59% of men unable to achieve orgasm alone or with PVS could achieve orgasm with the addition of midodrine. Midodrine in particular is often used in men with SCI-induced hypotension, and it has been studied and found to be a safe adjunct to PVS for ejaculatory dysfunction in SCI patients. However, you do need to monitor blood pressure, as it can increase blood pressure, promote AD, and may cause urinary retention. I was not able to find any studies that looked at the use of midodrine in women with SCI. However, it may be reasonable to try in a low dose with blood pressure monitoring. Lastly, Viagra has also been shown to increase the chance of orgasm and ejaculation in men with SCI. And autonomic dysreflexia has been reported with sexual activity in those at risk, so those with lesions at T6 and above. And interestingly, it may be responsible for some of the pleasurable sensations interpreted as orgasm after SCI. These episodes of AD are often asymptomatic, and there's some debate about whether or not all these episodes can really be classified as AD, because a rise in systolic blood pressure is also seen in neurologically intact individuals during sexual activity. Additionally, the dangers of these transient increases in blood pressure during sex are not clear at this time. Most of the research mentioning sex and AD actually just refers to the fact that the risk of AD is often a major deterrent to sexual activity for people with SCI. You can consider pretreatment with prazosin or nifedipine, but then you also run the risk of hypotension once the episode is over. Regardless, you should educate susceptible patients about the risk of AD during sexual activity. Lastly, remember that people with spinal cord injury can have an active and rewarding sex life. Thank you so much for your time and attention.